Hi, my name is Brennan Spiegel. I'm Director of Health Services Research here at Cedars-Sinai Medical Center in Los Angeles. And I'm pleased to welcome all of you to our latest online webinar from our VR program here at Cedars-Sinai, where we'll be unveiling the top 4 VR research projects of 2020. So about a year ago, we put out a call for applicants to submit their very best research for a new annual research competition as part of our virtual medicine or vMed conference at Cedars-Sinai. Now, originally we were going to host this live in March, but of course, because of the pandemic, we were not able to do so. But today, we're really pleased to invite the top 4 winners of the abstract competition to each present their research in a brief 10-minute presentation, followed by a 5-minute question and answer period where we'll be discussing some of the finer points about the research. Now, we received well over 30, I think almost 40 research projects from around the world, and it was really a very difficult decision for picking the top 4. And we looked at all of them in terms of how innovative they were, what the topic was, and how broadly important that topic was, and the quality of the research methodology to select the top 4 abstracts that you'll be hearing about today. And so we'll hear about those projects soon enough. We've highlighted these projects in particular because we think they're very impactful. In fact, many of them I've written about in my own book. Some of you may be aware that based upon our own research at Cedars-Sinai and beyond, we published this book just recently. It's called VRX, How Virtual Therapeutics Will Revolutionize Medicine. And this book is now available wherever books are sold. And in the book, several of the research projects that are discussed today are in this book. So take a look and grab that if you're interested to learn more. You know, in general, this is a turning point for immersive therapeutics. I think when most people who don't follow this literature think about VR, they think about a gaming platform, you know, for pimply teenagers playing first-person shooter games in their parents' basement or something like that. And of course, VR is for entertainment, but it's more than a gaming platform, and we've known this for a long time. We know that VR can profoundly modify the human mind and the human brain and the body. It can do that to support gaming and entertainment, but also to support human health in really profound and interesting ways. And we now have well over 5,000 studies from around the world supporting the benefits of virtual reality in healthcare. And what we're trying to do here is to continue to advance the science. As we get more and more knowledge and sophistication in doing this research, we're learning about what works and you know, what doesn't work. So we'll hear a lot about that today in the 4 presentations. So I'm just going to share my screen here to get us started for today's presentation, which we've entitled The Best Clinical VR Research of 2020, as determined by our judges, who we'll be hearing from some of them today. And so here's the layout for today. Before we get too far, I also just want to refer you guys to our website, where you can find a lot of resources, including the speakers for today's webinar. If you go to our webinar series, you can see the webinar for today, and you can even access the research abstracts directly by clicking on the button or on the title of each presentation. All of our previous webinars are also available down below, and we have videos from the previous webinars and all of our previous talks. You can find our research, including all the abstracts submitted, and we have a new clinical resource page where you can find a VR provider, and that registry is growing. Plus, we just posted this page of our favorite VR programs. We're frequently asked, what programs do we use with our patients at Cedars-Sinai? And these are some of the programs that we use that we have now put for everyone to see. And if you have an idea for an evidence-based, high-quality therapeutic VR program to add to this, please let us know. You can contact us. There's also more information on this page about the book VRX, and you can order it directly from this page as well if you'd like to learn more. So here is a list of the speakers for today. I will be asking some questions along with Brandon Burkhead, who's in the bottom right, also with us at Cedars-Sinai, and we made up 2 of the judges that reviewed the different abstracts, and the other speakers are all listed there as well. We'll be hearing from Gideon Bloomstein, who conducted a randomized trial of a VR tool to teach surgical technique for tibial shaft fracture intramedullary nailing, a very innovative and very interesting study. You'll hear more about that shortly. From Melissa Boudon, who has been conducting very interesting research with avatar therapy in treatment-resistant schizophrenia. This is a topic I also discuss in the book. Really pleased that Melissa will be representing her team from the University of Montreal. It's one of the 4 top abstracts that we'll hear about. We'll also be hearing from Victoria Gulick at Jefferson Health, who conducted a study entitled Effect of a VR Enhanced Exercise and Education Intervention on Patient Engagement and Learning in Cardiac Rehabilitation. And our last speaker, who is going to be, in fact, our first speaker, is Bhumit Desai, who is going to present a study on the efficacy of a VR, of virtual reality in pain reduction in orthopedic pediatric patients measured by patient feedback and heart rate monitoring. Bhumit is an orthopedic resident currently at Ochsner Health in New Orleans. And he works in their 3D lab to facilitate patient education and enhance training of physicians using health technologies like virtual reality. And in this first talk, we'll hear about how he's been using that out down in Ochsner. So thank you, Bhumit, for being one of our 4 finalists, and take it away.
My name is Bhumit Desai. I'm an orthopedic surgery resident here at Ochsner Health in New Orleans, Louisiana. And today I'll be talking about one of our projects using virtual reality in pediatric orthopedics as it applies to reducing pain and anxiety associated with clinic procedures. So just a second, I'll get my slides pulled up. All right. So the title of our study is the efficacy of virtual reality in pain reduction in orthopedic pediatric patients measured by patient feedback and heart rate monitoring. So what does that mean? So a little bit of background about myself. I'm currently just starting out doing my orthopedic surgery residency. But to backtrack a little bit, as a medical student here at Ochsner, I had the unique opportunity to get involved with a group called Innovation Ochsner, and more specifically, the medical 3D lab within that branch. And what we aimed to do was using technology, including additive manufacturing, virtual reality, and augmented reality to deliver healthcare. And that the 3 pillars of essentially what we did focused on patient education, surgical planning, and enhancing medical training, not only for residents, but also for medical students and staff alike. Some of the projects that we were involved in, here's some pictures. This is our lab director, Dr. Sarkar, with one of our vascular neurologists and patients demonstrating live a case where we use virtual reality. So what's unique about what we do is that we're completely integrated within our patient's workflow. So the virtual reality setup is part of their clinic visit. They come in. This helps the patient to understand the anatomy and the pathology that we are treating them for. And it has made such a fast and significant impact in the relationship and understanding that our patients have. Here to the left, you can see a list of just a few of the specialties that we're involved in with our medical 3D lab through Innovation Ochsner. Here in the last on that list, you can see the pediatric orthopedics part. And so kind of diving into our specific project, what we aim to do is use this virtual reality technology within our pediatric population. And so clinic procedures that we were particularly involved in were cast removals, hardware removals, and as well as fracture reductions. Now, virtual reality within the pediatric population hasn't really been studied when it comes to orthopedics. There is some utility in the literature as it applies to pediatric oncology patients for accessing port sites and receiving IV infusions. There has also been utility that's been shown in adult burns patients for dressing changes using distraction therapy to sort of decrease patients' perceived pain and anxiety. So we thought that by, exploring distraction therapy in pediatric orthopedics would be something very unique and just help out with our kids Because if you've ever had a child who's broken an arm or taken them to the orthopedic, when you hear that saw come on, and it's something that they've never encountered before, it can be extremely distressing to them. So in the literature currently, studies have shown through subjective means, using patient feedback and pain scales to show that there is a benefit. However, we wanted to take it one step further and add an objective means of monitoring. And so that's where we came up with the idea of heart rate monitoring. And so to dive in a little bit deeper about the study itself now, we looked at all the kids who were coming into our clinic aged 5 to 18 to catch a wide variety of patient population. And the procedures, like I mentioned, were getting their cast taken off with a saw, pin removals, and fracture reduction. So these are all acute type of processes that we see in our clinic regularly. Through our Innovation Nostril Medical 3D Lab, we had developed in-house a rock skipping app through the virtual reality Oculus Quest headset. And essentially, to describe the setup, the patient would put on the headset, they would be fully immersed. There's sounds, the screenshots on the right side of the screen showed a little bit, and you're fully immersed on this lake. There's birds chirping, there's peaceful music playing, and the remote controllers allow you to essentially skip rocks. And so that added an interactive component to the distraction therapy. And with our patients were stratified either into the VR group or the control group, where there was just a standard of treatment, no headset. And the things that we were looking at was the baseline heart rate. So when they came in, that would be our way to control or compare. And then the peak heart rate during the procedure of removing the cast. And then finally, at the end of the procedure, we would ask patients in both groups what their perceived pain and anxiety was based on the scale seen on the screen. And so interestingly, overall, we were able to enroll about 95 patients. Our goal was to reach 100, but unfortunately we had to cut enrollment short due to the coronavirus and concerns over infection control, but we were happy with the 95 that we were able to enroll. And majority of them were males. The average age for our population was about 10 years old. And as you can see, I mean, there's a staggering difference here seen in the graph on the right, that the change in heart rate seen in patients not using the VR headset was significantly greater than those who had the headset on. And this, once we looked into it a little bit further, this difference was also statistically significant. The two bars on the very right also show that patients who were in the control group had a higher perceived pain and higher perceived anxiety compared to those who were using the headset for distraction therapy. And I think the most unique aspect or finding that we had was that we had 13% of patients in the VR group whose heart rate actually decreased during the procedure, whereas that happened for 0 patients in the control group. When you talk about the importance and applicability of this research in virtual reality as a therapeutic form, this allows us to avoid using narcotics, avoid using drugs like ketamine and opiates, which overall reduces the morbidity and changes the perception of patients, especially pediatric patients, when they come in for treatment to our clinic. And so, talking about the big picture here for our study, when we talk about scalability, this is something that has been so successful with our first 95 patients that we anticipate using this moving forward regularly for all of our clinic procedures. One of the challenges that we had, coming into this was getting patient buy-in as well as clinical team buy-in. So there's a small level of education in terms of getting the team members trained in the technology, and also getting the timing and down for setting up the VR headset, making sure everything is charged, making sure there's a good way to explain to the patient exactly what's going on, getting their consent. And I think repetition really helped in getting those things really solidified, which by the end of our study, we had it down so well that patients were expecting this because they had heard about it from other patients. And in the future, when we talk about the implementation of this, we hope to extend this to the use of our pediatric emergency room. So, patients who are similarly undergoing procedures or testing that might induce stress and anxiety a virtual reality headset with distraction therapy could really help in those cases as well. Thank you all, and I'm happy to answer any questions that you may have.
Dr. Desai, thanks so much for that presentation. It's really interesting what you're doing, particularly from my mind. My first question that came to mind is, love the outcomes that you had, but one question I wonder is about sound. So when your patients are going through this, and you talked about the SAW and the challenges that the SAW presents from an anxiety standpoint, you talked a little bit about the experience that they had and the skipping of the rocks, but could you just dig a little bit into how does the VR experience itself help with sound? Does the volume ever get louder, or does it, were they hearing it directly from the VR headset, or did they have anything within their ears or next to their ears? Just curious.
Yeah, that's a really good question. So that SAW is extremely loud, louder than the volume of the VR headset. And so logistically, we tossed up the idea of using noise canceling headphones, and we even tried it out. However, we found that, for a patient, especially someone who's 6 or 7 years old, putting on that VR headset plus the noise canceling headphones was just a very lumbering task, and they weren't comfortable, whereas the whole point of this is to make them comfortable. And so we sacrificed that sound aspect of 100% sound cancellation. But we still found that, patients were okay with the noise, and it helped cover up the sound of the SAW. It's interesting taking away that visual tactile of the SAW coming on, because, for kids, when they hear that SAW come on, it's terrifying. But when you actually feel the SAW, if you've ever had a cast cut off, there's no pain whatsoever. If anything, it's just a slight vibration if you feel anything at all. And so once you take away that visual stimulus of the SAW, they actually don't feel anything. So to them, it's just a sound or a motor in the background.
Fascinating, fascinating. And so with these future implementations and studies that you're considering, what are your thoughts on the potential control group if you would consider either potentially other designs, so like waitlisting, or could you imagine potentially having 2 different VR programs or a different type of intervention, again, to kind of help with some of the challenges that can be with recruitment into a control study? What are the thoughts right now as far as moving forward, do you think?
Sure. So again, one of the issues that have come up is, while a beautiful serene lake with music and skipping rocks is great for a patient who might be aged, say, 7, 8, 9, 10, well, for the 14 to 17-year-old, they get bored very easily. And so one of the things that we're adding to our rock skipping app 2.0 is a more challenging dimension. And so as you could see that lake, and we were planning on putting rings in the air at different levels, and so they could aim to shoot the rocks, because I think that would be extremely helpful for our older kids. Interestingly, that's pretty consistent with that, is that the improvement in heart rates was higher in our younger population, whereas for those older kids, the variability was much smaller, which makes sense, where they might have gotten bored within the first 30 seconds of the lake.
Yeah, it even sounds like something I might want to just try out. I can imagine a surgeon maybe wanting to get in with the full team to see how high of a score you can get with the program. That's fantastic. I think this is great. In talking about where this goes moving forward, you talked about the ER. Has there been discussions with going into the ER? In the past, I've worked with ERs to see if we could start up a study, but that's also adds a level of, I want to say chaos, but there can be a bit more challenge in the pressingness of the ER. Had there been any beginning discussions or about challenges, or even just implementation in that different setting?
Sure. So the challenges that we've come across, number one, from an IRB standpoint, is patient consent. And so while we have our consent process down, the second thing that ties into that is the timing and craziness of an ER. And so, for us as orthopedics, when we go into the ER to do a fracture reduction for a patient, there's already a million other things that you have to line up logistically. And so if you were to add consent and setting up the VR, well, where do you store it? Where do you make sure that it stays safe and secure? Who's going to be in charge of that? Is it going to be the orthopedics? Is it going to be the ER? Logistically, there's a lot of challenges there. And while we've started those discussions, I think getting buy-in, like I mentioned, from the people who are actually there is going to be a big part of it. So that's what we're working on currently.
Fantastic. I love what you're doing, and love the moving the field forward in this area for pediatrics and pain and anxiety. I think I'll leave it at that for questions that I have, but keep up the great work.
Thank you so much for having me.
Well, thank you, Brandon and Bumit, for that great first talk. I'm now going to introduce our second speaker for our webinar. Dr. Gideon Bloomstein is the Chief Orthopedic Resident currently at UCLA Medical Center here in Los Angeles, across town. And he is interested in surgical outcomes, particularly of the spine, but he's also more broadly interested in surgical education and evaluating and implementing new technology in the operating room. So he's going to be presenting to us a randomized controlled trial comparing what is a very novel VR educational platform developed by OSO VR versus standard surgical education to see how it actually impacts the performance of surgery. And it's a very novel, interesting study. So with that, Gideon and Dr. Bloomstein, the floor is yours. Look forward to hearing your talk.
Thanks very much, Dr. Spiegel. So I have to beg your pardon for the mask. I'm in clinic and we can't take it off. So it's kind of it's part of our times here, but I hope you'll be able to hear me well enough with it. Surgical residents are expected to master a large number of procedures during the training period in residency. The problem with that is that in recent times, and this goes back, depending on who you ask, over the last 20 years, the time that surgical residents have to practice procedures and spend time apprenticing in the OR has been cut back due to, in part, work hour restrictions, as well as increased non-clinical administrative tasks. And when you combine this with the fact that in a lot of settings, patients aren't really willing to undergo surgery with trainees as the primary person providing the surgery, this has significantly affected the quality of surgical education. You compound this with the fact that more and more surgical procedures are coming online and sort of becoming part of the expected knowledge that surgeons are required to master during training, and this causes a significant problem. So this is an actual photo of a surgeon looking at a instructional manual during surgery. Some studies have shown that up to 31% of newly graduated surgeons, don't feel comfortable training alone. And the consequences in other studies have shown that medical errors due to lower skilled surgeons account for up to 250,000 deaths a year with a cost of up to $20 billion a year. And when we're trying to come up with novel ways of helping surgeons obtain the optimal training during the residency and potentially continuing to improve while they practice, virtual reality has come out and become I think a very promising new field. So the purpose of this study was to see, can we use a virtual reality program to improve surgical training, and does that data compare, when we compare it to the sort of traditional use of a technique guide, which is basically, if you imagine your IKEA furniture assembly instructions at a much, much higher level, but still some pictures and some line by line instructions. So in the study, we randomized 20 first and second year medical students who've never had any experience with any orthopedic surgery procedures, and who actually were excluded if they had significant experience with power tools, because there's some crossover there. A lot of the tools we use in orthopedics are somewhat similar to tools you'd find in wood shop or in other mechanic training situations. And so our 20 subjects were then randomized. 10 received oral instruction in the normal technique guide to use, and the other 10 received a short training procedure in a program called OSO VR, which is an orthopedics-based virtual reality training program, which I'll show you in a bit. Both groups were then tested on a Sawbones version of a tibial nail procedure. A Sawbones is basically a plastic composite model of a bone, which we use. You can drill into it and insert metal rods into it, and it acts, pretty close to bone for training purposes. The students were then filmed, and we evaluated them in two ways. The first is a global assessment scale, and this is just to see how well they worked with the tools, sort of the time and efficiency, economy of motion, knowledge of instruments, and the overall flow. And the second, the procedure-specific checklist is, we broke down the procedure that we were doing into steps, and it was whether or not they managed to do the step correctly. So the OSO VR procedure that we used uses a Oculus Rift headset and some hand controls. And I'll show you a video soon of the simulated operating room environment, which the user sees. And the nice thing about this product, although I think we tried to design our study in a way where I think the results are hopefully transferable to other modes of virtual reality training. The nice thing about this particular system is that they have a big library of different procedures. So you can use the same headset to do, and hand controls to do multiple different procedures. So this is what you see when you have the headset on. You can see your own hands. You can pull up x-rays, and it's done in a way that I think feels pretty similar to being in an OR. And so this is how you select your tools, and the system can be set up to have hard stops, or it can allow you to make mistakes depending on what level of training you do. And the nice thing is it also records your hand movements, and sort of allows us to have, beyond just whether or not you do the steps right, it allows us to look at your economy of motion and graph it, comparing your efficiency each time you practice the procedure. So the results of the phase 1 study is that overall, that the students who trained with the virtual reality of the OSO VR system performed significantly better across all categories compared to the students who used the traditional written instruction manual. And here is a video, side-by-side sort of comparison. The student on the left used the traditional written guide, and the student on the right was trained using the virtual reality simulator. And we can see procedure was completed in 6.5 minutes, and all the steps were performed correctly. The student who used the traditional guide required some clues, which we also account for, and took almost twice as long to complete the procedure. And so when looking at the procedure specific checklist, there's a 230% improvement with the OSO VR training compared to the traditional training method. We then had the students return 2 weeks later to see, how well they retained their knowledge. We had a little refresher where they're allowed to either reread the traditional guide for 20 minutes or go through as many cycles of the virtual reality program within 20 minutes as they could, and tested them again. And what we saw this time is that this overall percent improvement between the first and second phase was significantly higher for the students who trained with the virtual reality. So this suggests, everyone improved the second time around, including the students using the standard technique guide, but the students using the virtual reality had a significant improvement. And I think this is an important concept to think about, which is, this is something that you're going to be using over and over to train. And if we have data that suggests that the more you train with a specific program, the quicker you're going to improve, I think that's going to be very valuable for training purposes. And so in conclusion, our study found that our virtual reality training was more effective than the standard training model, and could potentially be a useful and cost-effective method to help augment orthopedic surgery resident training.
Well, thanks so much for that presentation. Really interesting, and the videos, I think, really tell the story well when you look at the side-by-side performance of those selected videos. Now, obviously, you showed us one particular side-by-side. Was there anyone who actually did better who with the usual care, with the manualized learning, or did every single individual do better in the VR group?
Every single individual did better. There were some that were much closer. There's a couple in the VR group that still struggled compared to the rest, and a couple in the standard guide who seemed to get it much faster. But overall, everyone seemed to do better, at least in some of the categories with the VR training.
Because obviously, some people are maybe more naturally talented at manual processes, but in any event, you're saying that it wasn't just on average, it was actually almost every single person, if not every person, which is impressive.
Correct.
Now it's a pretty small sample. I mean, it's very impressive, but how did you decide to go with 20 to 10 per group? Was there sort of a sample size calculation, or did you just sort of convenience? Or?
We did a power analysis. It's also sort of limited by the number of appropriate students that we can get involved. I think it'd be nice to certainly have a larger group, but at 20, that was sufficiently powered to look at what we're examining. So
right. Now you may have mentioned this, I'm sorry if I missed it, but the people that evaluated with the global assessment, were they blinded to how?
Yes.
They were blinded? Okay.
Yes.
So they did not know. They might have been able to figure out pretty quickly, but they didn't know in advance.
So they picked, exactly, with the exception of a couple of students, because we kind of wanted to see whether they could pick who had which kind of training. And with the exception of those same two, or I think it was three in one group and two in the other, that either did sort of worse than the rest of the group or better than the rest of the group, the evaluators were able to guess what kind of training the students had just based on their performance. But they were blinded. Yeah, the videos were cut short. The students were instructed not to discuss it with anyone, not to discuss what training they had, not to refer back to it. And a couple of times we had to edit the videos to make sure that was the case. And so the evaluators, didn't have any insight as to what kind of training was had, which I think is one of the strengths of this particular study.
Right. So of course, this was a model surgery. How do you think, how well would this translate into actual surgeries? And what would be the next step to evaluate whether this really changes outcomes in the actual performance of this procedure?
So I think one of the, we chose this procedure because it was simple to simulate, in real life. I think one of the unique challenges in orthopedic surgery is that we have surgical procedures across the entire body and different systems. A lot of our surgeries involve implants. And those implants, even the ones that are very similar, have slight differences. And then there's differences in the manufacturing and the tools associated with them. So how you put the implants together, how you use the tools that come along with them is different for each procedure. And I think so that's a unique thing in orthopedics that allows us to address that specific problem, which is we can potentially design a training module for each system so that you can become proficient. The part of the surgery that requires the dissection and the skills, I think at this point, this particular program is not really designed to work on that. But there's sort of a lot of low-hanging fruit with just the tools and the implants that we use where we can make the improvements. I think the next step would be to, and I think it's already being done, the wider implementation of the also VR system through various training programs across the country and collect data individually for residents. So as part of the training, it's going to become, in some of the programs, it's going to become required that students log or residents log a certain number of cases for each procedure. And we can sort of generate analytical data to see their improvement and then hopefully compare that in the future to what their attending surgeons and the people who train them, the mentors, sort of gauges their success doing the surgery and knowing what they're doing.
Yeah, well, I think that's the key is taking this to the next level and scaling it and seeing what the impact is on actual clinical outcomes. What I think is really interesting about this is not only are you training the surgeon what the steps are, but also evaluating their efficiency and motion, efficiency of motion, and the time that it takes to do the procedure. Because we know that the longer somebody's under anesthesia, the greater the risk, and also not just the risk to the patient, but also the risk to overall operating room efficiency. If somebody's in the operating room for a shorter period of time, this helps the bottom line for hospitals who can book more cases per unit time as well. So these are some of the sort of health economic consequences of this. And I think, even going the next step would be to see, could you actually improve overall efficiency of a unit if people are all trained this way? And what does that learning curve look like? Or is this really just something that's going to help the sort of lower end surgeons, during their training, or will it help everybody? So these are some of the open questions, but really want to thank you for being with us today and taking time out of your busy clinic there, and keep the mask on, please. I'm glad to see you get the N95 on. And we'll let you get back to your clinic, but thank you for sharing this really interesting research. And I think it's a great example of conducting, a randomized control trial, and really well documented. And I really love the objective evidence that you've collected in addition to the subjective evidence, the global assessment. You also have objective data, which just lends additional kind of credibility to your results. So thanks again for being with us today.
Thank you for the invitation. It's been a pleasure.
Okay, well, it's my pleasure to introduce our next speaker for the webinar, and that's Melissa Boudon from the University of Montreal. Melissa is both an MD and PhD student at the University of Montreal, where she works in the lab of Alexandre Dumas, who is focused on understanding the role of virtual reality for schizophrenia. Melissa's work focuses on VR in psychosis, and particularly treatment-resistant schizophrenia. This is an area where clinically very challenging to manage these patients, and traditional medical therapy and traditional cognitive behavioral therapy often is not very effective. So she'll be sharing with us the results of an interesting study evaluating predictors of treatment response among patients with treatment-resistant schizophrenia who undergo a form of trialogue therapy using a virtual reality avatar of their inner hallucinations. So with that, Melissa, you're up. Thanks for being with us today.
So hello, everyone. My name is Melissa, as you just said, and I'm a PhD student at the University of Montreal under the supervision of Doctors Alexandre Dumas and Stéphane Potvin. I am very pleased to be here today, well, from home, obviously, to present a small study carried out to try to predict which patients with treatment-resistant schizophrenia will respond best to avatar therapy. So first, I will start by briefly explaining what is treatment-resistant schizophrenia. Then I will explain what avatar therapy is, and finally follow up on the prediction of responders. Schizophrenia is a chronic and severe mental disorder that negatively affects the functioning of those living with it. It is characterized by distortions in thinking, perceptions, emotion, language, sense of self, and behavior. When we think of schizophrenia, the first symptom that comes to mind is that of hearing voices. That is called an auditory verbal hallucination, and it is indeed the most distressing and common symptom in schizophrenia. Even though antipsychotic medication is usually effective to reduce psychotic symptoms, about 30% of patients with schizophrenia don't respond adequately, despite an adequate dosage and a proven adherence to treatment. When patients fail to respond to at least 2 trials of different antipsychotic medication of at least 6 weeks, they are said to be treatment resistant. So what else can we do for them? Recent literature suggests that new approaches focusing on the patient's experience of their voices could be effective. And that's kind of the principle of avatar therapy, which is a novel psychotherapy using virtual reality to treat auditory hallucinations in patients with treatment-resistant schizophrenia. Avatar therapy is a psychotherapy of 7 to 9 weekly 60-minute sessions. The objective of the first session is to create an avatar in virtual reality that represents the patient's most distressing voice, as much as by its appearance as by the intonation of the voice. It is indeed common for patients to hear several voices, but these are not generally all negative or problematic. The therapy thereby only focuses on one voice. During the 8 other sessions, between 5 and 25 minutes are allocated to immersion, during which the patients are encouraged to enter into a dialogue with their avatar, which is animated by the therapist. This approach allows patients to develop effective prevention strategies as well as a better relationship with their voice. Which brings us to the next point, which is the prediction of responders. Since some patients respond better than others, we try to determine if they have specific characteristics that could allow us to distinguish them before starting therapy. What we found is that 3 months after the end of therapy, 40% of patients had a reduction of 20% or more in their hallucinations, which were measured using a standardized scale called the PSYRATS. To better understand the characteristics of the responders, we first identified the best baseline predictors, so measured before the therapy, using logistic regressions on 38 patients who underwent avatar therapy to date. Then the recorded and transcribed immersion sessions were on that we carried out a content analysis. So first, conducting backward logistic regressions on baseline variables, so variables measured before the therapy, we were able to identify 2 significant predictors of therapeutic response. The first one was the education level. So the further the patient had gone in their academic career, the more likely they were to respond well to therapy. The second predictor was a lower level of positive symptoms, which are symptoms that are added to an individual's normal functioning, such as hallucinations, delusions, or disorganized speech. In contrast, people with schizophrenia can also suffer from negative symptoms corresponding to a loss of function, for example, a lack of motivation. Also, we conducted a content analysis of the therapy sessions of 18 patients. We were thereby able to identify the main themes that emerge from the speech of the avatar as well as from the patients. These themes have also been divided into more specific sub-themes, resulting in this grid. Once all these themes have been identified, we annotated each transcription in order to classify each sentence or each idea into a sub-theme. And finally, in order to compare responders to non-responders, we have graphically illustrated the percentage of words allocated to each theme in each session. So the first thing that we notice here are the differences regarding self-criticism. As you can see, responders were more likely to value themselves, especially during the 4th session. As an example, the patient could say something like, I am kind, intelligent, loyal, honest. I am worth something, I am a human being. This result is unsurprising because the main therapeutic target of this specific session is self-esteem. What is interesting is that responders also seemed more likely to devalue themselves than non-responders, even though it is less frequent than self-valuation. For example, they would say, I doubt my intelligence. Therefore, responders probably have a better self-criticism in general. As for beliefs about the voices, responders seemed more likely to think that the voice was malicious. For example, by saying things like, you are mean, you are spreading misfortunes to everyone. While non-responders express themselves more about the omnipotence of the voice. For example, I would be surprised if you leave. I have hallucinations in my head and I don't know how to stop it. It is also interesting to observe that for responders, the belief of maliciousness seemed to decrease as the therapy progressed, as if the patients were developing more positive relationships with their voices. In comparison, the beliefs of non-responders varied very little over the course of therapy. During avatar therapy, especially during the first sessions, the avatar uses confrontational technique in order to encourage the patient to use coping mechanisms. These mechanisms can be divided into several categories, such as self-affirmation. Yes, I will be able to do this. Or negation by saying things like, no, or I never said that. Or counterattacks with something more aggressive, such as change the subject. You ask the same questions all the time. As shown, you can see that responders seem more likely to respond with assertiveness, which is again a sign of good self-esteem. On the other hand, non-responders tended to react in a way that could be described as less mature, either by simple negation or counterattacks. In conclusion, these analyses allow for a better understanding of the therapeutic processes of avatar therapy. A next step we've been working on this year is to use machine learning in order to annotate the transcript automatically, which saves us a lot of time because the results I presented to you were done manually by one person, and also allows us to analyze a large sample to predict responders. For example, we can consider the frequency of appearance of a team diet. So a team following another one. For example, what does it mean when the avatar uses a specific confrontational technique, such as threats, and the patient responds in a certain way, let's say with a negative emotion? Obviously, these discoveries have important implications in terms of personalized medicine because they could allow therapists to determine the best possible therapy for a given patient, or even how to optimize the therapy in order to make them respond better. So normally I suggest to people to come to me and ask questions, but obviously it's not possible for those of you watching the video, given the current context. So if you have questions or if you want to know more about the therapy, please feel free to contact me by email. Also, I'll just quickly go over my references so you can, oh, I'm having trouble here. Oh yeah, okay. So you can pause the video and see them if you want. And thank you very much for listening. And also just show you a video of this setting of avatar therapy.
Well, thank you, Melissa, for that really interesting research that's getting into this idea of kind of precision immersion, the idea of who is it that responds. We know that VR doesn't work for everyone, every time, for every condition, just like pharmacotherapies don't work for everyone. And this is a really important project, not just because of the paradigm of using avatar therapy for treatment-resistant schizophrenia, which itself is fascinating, but also the notion of trying to understand who is going to respond, which hopefully can help us more precisely use this therapy in the right patient at the right time. So there's a lot to talk about in your presentation. And so to me, one of the main results was just statistically, in your sort of stepwise regression, you found a couple predictors, and one was education. And education, about a 1.5-fold increased probability of responding. What is the theory, you think? Is it that people who are educated are more self-affirming, value themselves more, which is what you found later? Or do you think there's something else altogether different? What's the mechanism, you think?
I'm not sure what is the mechanism, but definitely it's maybe that they understand the therapy better, or that they understand the goal behind it, and they can like enter more into the role, or like into the role play, let's say. I would think it's probably something like that. It's probably a matter of comprehension.
Okay, so maybe literally just understanding what is happening in the therapy itself that allows them to get the most out of the treatment paradigm.
Yeah, I would not be surprised if the SERM effect were observed with the cognitive behavioral therapy also. I don't have the results at hand, so I can say for sure, but like I would not be surprised.
Brandon, you have some questions?
Yeah, one thing I thought also was interesting is, so in the results, patients that responded used more positive techniques, I believe. Yeah. And you showed a slide on the positive and negative techniques, and you talked about that within the context of the content analysis. So just curious about, were those techniques that were taught during those sessions, or things that just kind of evolved as you saw them categorized, you know, during the process of the analysis? Just a little bit more info on when those techniques were brought up, either in the sessions or kind of thematically kind of pulled out later.
Yeah. Actually, I'm looking at the figure right now. It's hard to say because these results are preliminary. So the differences were not yet significant, except for the self-appraisal. So that's an important thing to say. So I can say for sure right now, but we're going to publish more results with the machine learning things we've been doing, and these results are going to be significant. But for now, yeah, so I'm looking at the figure right now, and actually at the beginning, responders already seem to have more self-affirmation. So yes, they're taught that during the therapy, because actually maybe I'll say a bit more about the therapy itself, but like the patient is talking to the avatar, which is animated by the therapist, but sometimes the therapist can also make interruptions when it's getting too intense, or if you want to redirect the patient. So he's like telling the patient, okay, maybe you could affirm yourself a bit more, maybe you could put your things on the table. So so yeah, these things are supposed to evolve over the course of therapy. That's the goal. So I'm not sure if this answers your question. Yeah.
Yeah, just a description on the techniques and
yeah,
what that was in the therapy. Yeah.
Okay.
So you noticed that the responders tended to have, maybe it was the non-responders who tended to have hallucinations that said things like, you know, I'd be surprised if you can get rid of me. I'd be surprised if you know, this works. Like which probably is a reflection of some self-doubt, but it made me think of this trait of locus of control. You know, some people have internal locus of control, some people have external locus of control. And the difference is, you know, internal locus of control, you feel as if you can control your illness. If you make the right decisions, whether it's taking a medicine or behaving a certain way, I have control over my illness. And this applies as much to psychiatric as to medical illnesses. Whereas external locus of control is a sense like, I've been dealt a bad hand, the stars are aligned against me, this is a disaster, there's nothing I can do. So I kind of got that feeling that if we were to measure locus of control, which there are questionnaires for, that itself might be an overarching domain or trait maybe that might actually predict response. So it's just a thought, and I wonder if you have any thoughts about that.
Yeah, that's a very good observation. I don't think we have any questionnaire for that right now, but that would be a very good thing to add up. Definitely.
Yeah.
Yeah.
So that kind of gets to the last bit, which is, you know, you're using machine learning now to kind of more automatically evaluate these transcripts. But so kind of big picture, how do you think this could be used clinically, you know, to pick and choose, you know, the right patient for this therapy?
Yeah, so that's not exactly my domain. So, but I believe that you can use algorithms and like kind of a program, and you can set like several factors for the patient, and the algorithm could tell you, for example, the person has X% chance of responding well to therapy. I don't know how it could translate for now for this therapy, because for now it's still experimental, but definitely that could be something that would be used. But for now, I believe that these results are mostly useful to try to understand more the illness and to try to understand more how the therapy works, maybe also for the formation of future therapists, to make them understand how it works better, and in order for them to obtain the same results as well, because the results I presented to you were all it was all done by one therapist, and right now we just formed another one, but like we wanted because right now it's very effective, but we wanted to stay effective and give a good training to new therapists.
Well, you know, it's a big commitment to put somebody through 7, 8, 9, 10 weeks of therapy, and it would make sense to know in advance if somebody's going to respond to that with some degree of predictive validity. So, I mean, I can see it being a very valuable approach before committing to this long-term, you know, relatively long, it's not long-term, but it's several weeks of work. So, you know, it would be, it makes a lot of sense. So anyway, we congratulate you on this work, not just for advancing the science of avatar therapy, which is really powerful stuff. And your and Dumay's work has been very impressive in terms of the effect sizes that you're seeing compared to traditional cognitive behavioral therapy and compared to medications, but also to focus on the sort of predictive validity piece. So thank you so much for being with us today, and we appreciate your time.
Definitely.
Thank you very much.
Thank you.
Okay, our next speaker is Victoria Gulick, who is currently the medical research coordinator for the Jefferson Health XR laboratory. Victoria designs and implements research to validate XR technology for use in healthcare. And she's been particularly interested in evaluating XR solutions to improve the patient experience, particularly around cardiac rehabilitation and bone marrow biopsies. She's presented her research widely in international conferences, and we're really pleased that she, as she says, is a firm believer in validating the benefits of virtual medicine, and she's passionate about advancing the healthcare community's understanding of XR technology. And that's part of the goal of today, is to understand what is valid and maybe what still is a work in progress. So today she'll be talking to us about her research using virtual reality with cardiac rehabilitation. So Victoria, thanks so much for being with us today. And it's your time to take the floor.
Well, thank you, Dr. Spiegel, for that introduction. I'm happy to be here today. So I'm going to be talking a little bit about virtual reality for cardiac rehabilitation. To start, I want to talk a little about the inspiration for this research. 655,000 Americans die every year from cardiovascular disease, which accounts for nearly 1 out of every 4 deaths in the US. And attending cardiac rehab reduces a person's chance of death after a cardiac event by about 30%, depending on the age of the patient and their diagnosed heart condition. And for some patients, that's actually as high as 50%. Depending on, again, their age and diagnosis. And yet, up to 40% of cardiac rehab patients don't finish treatment. There's a few reasons for that. Many patients aren't able to take off time from work. They can't get transportation to and from sessions. Their insurance doesn't cover everything. But even when you account for all of those things, research says that there are still patients who find it uninteresting and who don't understand the importance of it. So we decided to try an alternative method of engaging our patients, virtual reality. So why VR? At the start of this project, only a handful of studies had looked at VR for cardiac rehab. When it was used in at-home treatment, over 60% of patients reported being motivated to keep exercising after their treatment. So we decided to try and see if the same was true for outpatient cardiac rehab. Additionally, We found that in physical therapy, patients had seen a 9.5% improvement in their distance walked through a test similar to the one that's used in cardiac rehab, which I'll touch on in a few minutes. Usually when I talk about virtual reality, I'm referring to the head-mounted display units, goggles, glasses, things you wear over your eyes. But for this setting, using headsets wasn't practical. So by focusing on the immersive parts of VR that make it really impactful for patients, we found a solution that we hoped would improve our patients' outcomes while also keeping them safe during rehab. So we partnered with a local startup called vMed, and together turned their platform, Bionautica Trails, into a program for cardiac rehab patients. The setup includes a high-def TV turned vertically in front of a treadmill, a set of wireless headphones, which were noise reducing but not canceling so that patients could hear staff, and the trails themselves. Patients had the option of choosing from 7 uniquely themed trails. These were mostly nature trails, and there was also a space environment. And while walking on the trails, patients saw digital tokens appear. And when walking through them, it triggered a randomly selected cardiac rehab education topic from key categories identified by their nursing team, covering diet, exercise, the key things that you need to learn while in cardiac rehab to keep the things that you learn there throughout the rest of your life. So a few examples of some of these trails. This was the water-themed trail. It included a spot where rain comes down and walking over a stream. And the space-themed one called the Void, which was actually a favorite for a lot of patients because it really gave them a chance to experience a totally new environment. During the course of the study, we assessed 112 patients who were already starting treatment at the Methodist Cardiac Rehab Facility in South Philadelphia. We enrolled 72 of those over the course of a 1.5 years. And each patient was assigned to complete between 18 and 36 sessions. 36 is the national standard for the maximum amount. And depending on their risk factors, they came for an amount somewhere in between those, averaging about 24. And 35 of those 72 completed all study requirements. These patients were mostly male, white, and in their 60s, which is typical for patients currently attending treatment at the facility, as well as nationally for cardiac rehab programs. For these patients, we were looking at 3 key variables. First, we wanted to see if VR had an impact on their overall improvement through the standardized test used for cardiac rehab patients in general, the 6-minute walk test. So a 6-minute walk test is something that patients do at both their first and their last cardiac rehab session. We ask them to start at one cone in a hallway and proceed and walk to another cone at the end of the hallway as many times as they can in 6 minutes. And then we compare their first session versus their last to see how much they've improved overall. Second, we were looking at knowledge retention to see if patients learning heart health information during the walking trails retained it better than those who were learning it through other methods. And third, we wanted to look at patient engagement and satisfaction. So as you can see here, there was a slight trend in favor of the intervention, but no statistically significant improvement over the control group for the 6-minute walk test. That's understandable given that the treadmill was one portion of the total treatment that they were undergoing as part of cardiac rehab. But still, the trend was nice to see. For knowledge retention, patients completed a 5-question education quiz at 3 different time points: their first session, their last session, and 2 months after completing treatment. These questions were considered key information that all patients should learn by the time they complete treatment, and are often areas that patients have problems. So remembering which medication is for what, how to search for the right types of heart-healthy foods while grocery shopping, things like that. All of these were multiple choice and had the option "I don't know" as an answer to hopefully discourage people from guessing and encourage them to focus on what they actually knew. So again, there was a slight trend in favor of VR participants, but At all time points, there wasn't actually a statistically significant difference. And again, part of that might be because, remarkably, a lot of patients had such strong knowledge base coming into it. You can see here that we averaged over 3 points out of a 5-point total at their first test. So it's hard to show improvement when you start at such a strong baseline. In terms of engagement, we did ask a few subjective questions on how patients view their treatment, but we also wanted to try and get an objective measure. At each session, they were told that they could complete up to 15 minutes on the treadmill. By allowing patients to choose how long to spend on the treadmill, it was hoped that they would spend time proportional to how interested they were. In theory, hoping that the intervention group would spend longer because they were enjoying the trails, and the control group spend however much they were motivated to do on their own. However, looking at the breakdown between the two, you can see that at most sessions, most patients completed the full 15 minutes. And those who did not typically cited coexisting health issues like arthritic joints, or they had to leave for another doctor's appointment as why they spent less time. And finally, for satisfaction, patients answered a series of Likert type questions, again at their final session. And across the board, were very satisfied with their experience. A lot of patients identified staff as having the biggest impact on their satisfaction, which was something we weren't expecting. In the free answer portion of the final survey, many patients highlighted how important the nursing staff was to their treatment. It's the reason they were able to be there and why they kept going, which was a great thing to hear, but it did mean that we didn't hear as much about the VR in that particular question. In that same final survey, intervention patients had an additional set of questions specific to their VR walking trail experience. They all had the option of agree, disagree, or undecided. And it was a series of negative perspective questions and positive perspective questions. So things like, I dreaded my time on the treadmill versus I enjoyed treatment more. And largely, for the negative ones, they responded with disagree, and the positive ones responded with agree. Though notably, the statement, I wanted to spend longer on the treadmill, resulted in mixed responses, which suggests that as much as patients enjoyed the trails, it didn't change their overall view of walking on a treadmill. When patients were asked to include any additional information about their experiences, a few of the reasons came to light for why maybe that was the case. A few said that they felt a little isolated from the rest of their class, and some said that the education groups and the trails themselves became repetitive over time. So those are both things that we would consider for research in the future that could be managed. But many included positive statements about the intervention and their experience overall, and the impact that it really had on their care. My favorite of these is one patient who told me it felt like hiking somewhere with his brothers. Truly an experience that he wasn't going to have otherwise in cardiac rehab. So to wrap up, I want to leave you with a few main takeaways. First, this intervention didn't necessarily show statistically significant improvements over the control, but some of that is likely due to the limitations in the study design. Second, some of those limitations might be addressed by using the walking trails in different settings, like at-home care or facilities where class size and timing don't need to be as regulated. Third, most patients responded positively to the VR intervention. Those who didn't had no serious side effects. And Bionautica Trail is actually still in use at the center today, a full year and a half after the study ended. So patients are still enjoying it. And finally, focusing on the patient experience is a vital part of improving overall health. Virtual reality may not be the right tool for every patient, but it absolutely has the potential to impact patient care, and we should keep exploring and validating how best to do so. So thank you.
Well, thanks, Victoria. That was really outstanding, very clear. Thank you for preparing that and for sharing your interesting research with us. So I like to say that sometimes negative is positive. Just because a study is negative doesn't mean that we throw in the towel and that this thing doesn't work ever. We can learn a lot from negative studies, whether it's in virtual reality research or otherwise. So I congratulate you on proudly presenting a negative study, just for starters. I think that's an important concept for all of us in the XR community to recognize that every study isn't positive in a world-beating result. Sometimes it doesn't necessarily work out. But it was marked that the qualitative feedback was so positive, and the fact that it's still in use, a year and a half later. So I guess one question that comes up is, do you think there's a lot of reasons why this study may have been negative, but do you think that you fully captured the positive experiences? Was there another outcome that might have shown a difference if you could go back and redesign the study? Or do you just think that there was kind of a ceiling effect where people were very satisfied with the care they were receiving at this excellent clinic, and you really couldn't even do that much better no matter what you used in their rehab? What do you think about that?
I think it's kind of a mix of both. I do think the satisfaction probably was capped out. I mean, we had 9s and 10 scores just based on their interactions with staff. I think that there was a possibility for maybe some of the education retention. If our questioning had been a little bit more robust, limiting it to 5 questions was trying to consider patient time, because we were building it all into the first session and taking that into account. So if that had been a little bit, again, more robust, that would have helped. I also think at-home care is a place where this could really shine, because you get patients who are able to then self-motivate and spend longer because they're able to, in whatever capacity they're exercising.
Got it. Brandon, you got some questions?
Yeah. So that actually follows up to the first question I was going to ask, which is, when I read this, it seems like I'm very curious about kind of the at-home use, because I think your research shows that maybe this may not be the best fit for every clinical setting. So I'm curious, when you kind of cited some of that at-home literature, was that at-home literature, they use controls at all, or in any of those, or is that an area of interest for the future to look at at-home care?
It absolutely would be for me. Logistics right now with COVID make it a little bit more complicated. Right. But absolutely, most of the research when we started all of this was at home with Connect or other virtual methods, not necessarily a headset. Some actually use like the Wii Fitness board for different things. Mm-hmm. But most of them were just an intervention group. There was no control to it. So I'd love to see something that validates between the two.
So as you mentioned, this was not in a headset. I think some purists might say, well, that's not VR, but from my standpoint, it's a form of VR. I mean, you are trying to replace reality with sort of an alternative world, an alternative fantastical destination, like being in space or in the moon or wherever. But there are efforts in three-dimensional VR to help with rehab, whether it's playing Beat Saber, or in measuring heart rate, along with that to try to titrate the experience within a limited range, or other types of Tai Chi and so on. Do you think that there's something about VR that, the three-dimensional experience of VR that might have made a difference if you're able to test a slightly different paradigm? Or what are your thoughts about whether the 2D was just limited?
I think, at least in that setting, 2D made a lot more sense. It's a small facility. We didn't really have the space to be able to give people like a 6 degrees of freedom experience. But I do think having people be able to move around and fully engage and immerse would have an impact, particularly despite any differences in patients. I mean, we had a few patients in their 80s who were loving having something new and interesting. So it was great to see that people were engaging with the technology regardless of their background.
Cool. Brandon, any last words?
Yeah, we got just one last question. That's just about the educational material that was provided. It seems like in the literature, there's kind of 2 different flavors, or a few flavors of VR education. Mm-hmm. And one of them is kind of this kind of empathic, fully immersive educational modules that may be used even outside of the exercise. And so I'm curious about, it seems like your patient population is very well educated, but is there any, I guess, thought on if there was like a key concept that maybe would need something like a 3D module to kind of explain the intricacies of why this is so important to the patient, or does it just seem like it just that ceiling effect of they came in just so much knowledge, no real key concept that was missing consistently in their education?
You know, it's interesting because the nursing staff were also surprised in how strong the answers came back, because frequently they have patients who need that constant repetition. So I wonder if it was, it may have been a ceiling effect, but there may have been parts of it that could have benefited from more visual representation as opposed to just the auditory education. I would have loved to see if we had more development funding, have like a trainer in the trails teaching them how to do certain exercises or showing them nutrition labels, things like that, that absolutely could have made a difference.
Great. That's all my questions. Did a fantastic job. Thank you.
Thank you.
Well, we'll leave it there. I want to thank you again for this really interesting research. Keep up the great work, and we look forward to reading your next study when it's ready to go. So thanks for being with us today.
Thank you so much for having me.
Well, thank you again, Victoria, for that presentation, and to all four of our speakers today for presenting a really interesting set of topics and studies that reflect the breadth and the depth of this evolving new field of medicine, medical extended reality, or MXR as it's now called. And these four studies really exemplify such a range of opportunities for using VR in healthcare. We heard about examples using it in mental health, for example, with treatment-resistant schizophrenia. We heard about using it in surgery, for rehabilitation, in pediatrics, and as a tool to help train physicians to be even better at what they do. And this is just touching the surface of the possibilities using virtual reality in healthcare. If you go to our website, which is virtualmedicine.org or virtualmedicine.health, you can see many more examples. We now have a large library of lectures from some of the world's experts from our previous webinars and in-person conferences. And I encourage you to explore that library and learn more about how VR is being used all across healthcare, in surgery, in medicine, in psychiatry, in rehabilitation medicine, and so on. And the number of use cases just continues to expand. You can also check out our website for our latest research and to hear announcements for upcoming webinars. If you would like to be on our mailing list, you can contact us on our webpage and provide us with your email, where we'll be sure to let you know about all of our upcoming events. We're hoping to be able to see you all again in person sometime in the future, hopefully once we get through this pandemic, so that we can continue our enriching in-person events. But until then, we're going to continue with these quarterly webinars. And I want to thank you all again for being with us today. And again, special thanks to everyone who sent in a research abstract for the competition, and for the four speakers for taking time out of your day to be with us today to present your very interesting research. So on behalf of our VR research program at Cedars-Sinai, again, this is Brennan Spiegel, and I thank you again for being with us today. Until next time, take care and be well.